Hi everyone, I am Dr. Prabha, consultant ophthalmologist. Welcome back to Ophthalmology Made Easy and welcome to part 2 of our corneal anatomy series. In part 1, we covered the introduction, measurements, and the epithelium in detail. If you have not watched part 1 yet, please go back and watch it first. The link is in the description below. Today in part 2, we are going to cover 3 very important layers. Bowman's layer, the stroma, which is the thickest and most complex layer, and Dua's layer, the most recently discovered layer of the cornea. These layers carry enormous exam weightage. So get your notes ready and let us begin. Section 1. Bowman's layer. Bowman's layer is the second layer of the cornea, immediately beneath the epithelium. It is in a cellular mass of condensed collagen and proteoglycans. Its thickness is approximately 12 microns. It is not a true membrane. It is formed by the condensation of the anterior part of the stroma. This is an important distinction. Bowman's is not secreted by the epithelium. It is derived from the stroma. Composition: it contains type 1 and type 5 collagen fibrils, encased in a matrix of proteoglycans and glycoproteins. Function: Bowman's layer binds the corneal stroma to the epithelium, providing considerable resistance to mechanical injury and infection. It acts as a smooth base for the overlying epithelium, which is essential for maintaining regular refraction. It also helps the cornea maintain its shape. The most critical clinical point about Bowman's layer: once it is damaged, it does not regenerate. This is why any injury that penetrates through Bowman's layer leaves a permanent scar, and why superficial keratectomy scars and recurrent erosions that breach Bowman's can cause permanent visual disturbance. Now we come to the most substantial layer of the cornea, the stroma. The stroma contributes 80 to 85% of the total corneal thickness, making it by far the largest and most complex layer. Embryology. The stroma is formed by migration of the second wave of neural crest cells at the 7th week of gestation, after the epithelium has already formed. Remember, the epithelium forms first. Then, the neural crest cells migrate to form the stroma. This sequence is a commonly asked embryology question. Composition of the stroma. The stroma is made of corneal lamellae, which are composed of collagen fibers embedded in a hydrated matrix of proteoglycans and ground substance. The collagen fibers are predominantly type 1 collagen, with types 3, 5, and 6 also present. Type 1 is the dominant collagen. Please remember this. The stromal matrix is made of proteoglycans, specifically glycosaminoglycans, including keratin sulfate, chondroitin sulfate, and dermatan sulfate. These proteoglycans are highly negatively charged, and this gives the stroma its swelling property, meaning the stroma naturally tends to absorb water and swell. Control of this swelling, corneal detergescence, is maintained primarily by the endothelial pump. The proteoglycans are produced by stromal keratocytes, along with collagen. The key to corneal transparency: lamellar arrangement. This is one of the most important concepts in all of corneal anatomy, so please pay full attention. The collagen fibers in the stroma are arranged in lamellae. These lamellae are parallel to each other and parallel to the plane of the cornea, and they are homogeneous in diameter and spacing. This precise, regular, parallel arrangement is what gives the cornea its transparency. Now compare this to the sclera. The sclera also has collagen fibers, but they are arranged heterogeneously in an irregular interwoven pattern. So there is slight sexual dimorphism. Males tend to have slightly larger corneas on average. This irregular arrangement is why the sclera is opaque and the cornea is clear. This is a beautiful and frequently examined concept. Transparency requires regularity. Opacity results from irregularity. Regional differences in lamellar arrangement. In the anterior 1/3 of the stroma, the fibrils are obliquely arranged. In the posterior stroma, they are arranged at right angles to each other. X-ray diffraction studies have shown in the central cornea, the arrangement is parallel, while in the periphery, it adopts a concentric configuration, giving the peripheral cornea considerable strength and helping maintain corneal curvature. Clinical application. The parallel arrangement of lamellae in the stroma allows interlamellar dissection. This is the anatomical basis of lamellar keratoplasty, where individual layers of the cornea can be selectively replaced without replacing the full thickness of the cornea. DALK and DSAEK are both possible because of this layered lamellar architecture. Cellular components of the stroma. Keratocytes, which are fibroblasts present throughout the stroma between the lamellae, with flat cell bodies, large eccentric nuclei, and numbering over 2.4 million in total. They produce both collagen and proteoglycans, making them the maintenance workers of the stromal architecture. Also present are wandering macrophages, histiocytes, and a few lymphocytes. Functions of the stroma. 1. Acts as the transparent window for light passage. 2. Meshes with the surrounding sclera to form a rigid connective tissue frame, which helps maintain intraocular pressure. Section 3. Dua's layer, also called the pre-Descemet membrane. This layer was discovered by Professor Harminder Dua in 2013 at the University of Nottingham. This discovery changed the classical description of corneal layers from 5 to 6, and it is now a standard exam question in all ophthalmology postgraduate examinations. Location. Dua's layer is located anterior to Descemet membrane, between the stroma posteriorly and Descemet membrane anteriorly. Properties. It is 15 microns thick. It is acellular, containing no keratocytes. It is an extremely strong structure. It is impervious to air, meaning air cannot pass through it. This last property is clinically important. I will explain why in a moment. Composition. It is composed of type 1 collagen fibers primarily, with some amounts of type 4, type 6, and traces of type 5 collagen. Proteoglycans present include lumican, mimican, and decorin. Unlike the stroma, it has no keratocytes. It also does not extend peripherally. It is present only in the central and mid-peripheral cornea. Clinical significance of Dua's layer. This layer has revolutionized our understanding of several corneal conditions. In big bubble deep anterior, lamellar keratoplasty, DALK, when surgeons inject air into the deep stroma to separate it, the air tracks between the stroma and Dua's layer. Because Dua's layer is impervious to air and acts as a barrier. This creates a large bubble called the type 1 big bubble, which allows clean surgical dissection right down to Dua's layer, leaving the patient's own Descemet membrane and endothelium intact. This is the highest quality DALK outcome possible. Dua's layer is also thought to play a role in the pathogenesis of acute hydrops in keratoconus, where tears in Descemet's membrane allow aqueous to track between Dua's layer and Descemet's, causing the sudden corneal edema seen in acute hydrops. Key points to remember from Part 2. Point 1. Bowman's layer is 12 microns thick, acellular, derived from stroma condensation. Point 2. Does not regenerate. Point 3. Stroma is 80 to 85% thickness. Point 4. From second wave neural crest cells. Point 5. Dominant collagen is type 1. Point 6. Proteoglycans, keratin, chondroitin, dermatan sulfate. Point 7. Parallel arrangement gives transparency. Point 8. Anterior, oblique, Posterior, right angle, 0.9 over 2.4 million keratocytes. 0.10, Dua's layer discovered 2013, changed count from 5 to 6. 0.11, 15 microns, impervious to air. 0.12, basis of type 1, big bubble in DALK. Questions for you? Answer in the comments. Here are your 3 questions for part 2. Think carefully and drop your answers in the comments. I will be addressing these in part 3. Question 1. Why is the cornea transparent but the sclera opaque, despite both being made of collagen? Question 2. What is the clinical significance of Dua's layer in DALK surgery? Question 3. Bowman's layer does not regenerate. What are the clinical consequences of this property? The best answers get highlighted in part 3. So get writing. Thank you so much for watching part 2 of our corneal anatomy series. We covered a lot of high-yield content today. Bowman's layer, the stroma in full detail, and the newly discovered Dua's layer. If this class was helpful, please give this video a like. It tells me you want more content like this, and it genuinely motivates me to keep going. Share this with your batchmates and study partners. Because in medicine, knowledge shared is knowledge strengthened. Press the bell icon, because part 3 is coming very soon. And in part 3, we are finishing strong with Descemet's membrane, the endothelium, and the nerve and blood supply of the cornea, all of which are packed with exam-critical information you cannot afford to miss. And if there is any topic you want me to teach, drop it in the comments below. It will be my absolute duty to make that class for you as soon as possible. See you in part 3.